Okay, so the learning objectives for today's session are that by the end of the webinar, you'll understand the CPSA's Physician Practice Improvement Program and be able to talk about the requirements. List some tools that are available in the province to support PPIP requirements. And you will hear about a variety of examples of what physicians in Alberta are doing to fulfill their PPIP requirements. And I mentioned that Dr. Danielle Michaels from the College of Physicians and Surgeons is here, and she is available during the Q&A portion to answer any specific questions about PPIP. All right, let's get going. So easy peasy PPIP. Tips, examples, and strategies for doctors and clinic teams. And just a reminder, PPIP stands for the Physician Practice Improvement Program. And Jarrett Stevenson is going to be our first speaker. Take it away, Jarrett.
Awesome. Thank you, Dr. Craig. Yeah, so just a little bit of an overview. So in order to meet these requirements from the college, physicians have to do each of these three every 5 years. And so they include a personal development activity, a practice-driven QI activity, and a CPSA standards of practice QI activity. When you're going through your annual renewal, you'll need to report your participation in these within that cycle. And then once you've done those, you need to take your notes that are associated with the activity that you did and your action plans and hold on to them for about 6 years, just so that you can verify the activities that you've done in the setting where that becomes something questioned by the college. The piece about using the objective data here. So for the practice-driven project, you can dig into your EMR for a deep dive. Lots of EMRs have a wealth of knowledge that you can access. Not everyone's very comfortable with that. So if you're looking for some stuff that can also give you really high yields, where there's a lot of information at your fingertips, the HQCA panel reports, which we'll go into in a little bit here, as well as the MD snapshot prescribing from the College of Physicians and Surgeons are also really, really great ways to get actionable data. With respect to the CPSA standard of practice QI project, the goal is to use one or more of the currently existing standards as a reference point, and then use that to reflect on how it can relate to your practice and find ways to adapt or benefit different ways in which you're currently practicing. With respect to the personal development activity, looking at formal feedback and or self-reflection data is the key here. The multi-source feedback that's listed on the slide can come from something like peers, patients, and learners if you're doing, for example, some surveys in your office. Self-reflection data can come from addressing personal factors, such as the ones on the slide. It's quite important to know that the 2 QI activities require an action plan with respect to documentation. And then for the personal development activity, it's going to require getting that data, making sure that it goes through some facilitation, and then having an action plan. So a little bit of a difference between that third one and what you need to maintain for sort of documentation for that last bit. So next we're going to get into some resources that you can use to help you reach these goals. So starting with the CPSA website, where you can find lots of information about the PPIP program. There's lots of information, lots of resources. They actually have some programs, some suggestions on how you can go through these different activities. And they also have an action plan template if you're looking to reference one, and the activity that you're undertaking doesn't already have one. So there are some PCNs or some specific activities designed to accomplish PPIP goals that will have those attached with them. But if that's not the situation for you, you can always find one on the CPSA website. Another couple tools that people may not have heard of, the My L3 plan is a free online tool from the U of A. It helps to promote self-reflection to identify areas to advance your practice with an emphasis on developing a concrete plan for implementing practice changes. The U of C has a program called My Practice Improvement. There is an annual subscription cost for this program, but they do submit to the AMA CME Benefit Fund for reimbursement. We also have some webinars hosted with AC, such as Facing the Drain of Medical Practice, which can cover your personal development activity. And these are designed to be sort of pragmatic 90-minute sessions held in the evenings after your clinic day to help improve things like practice satisfaction while also taking care of your PPIP requirements. If this is something that you're interested in, your PCN hasn't run one, please get in touch with your PCN because we are still having those and hosting those for people. An additional one here, there is a study called One Care Path. It can be used as one of your QI opportunities. So this is a provincially funded research study using tools that have been developed to support care planning for patients with advanced stage chronic diseases while they're still in their medical home. So in sort of a place where you'd be getting longitudinal family physician care provided to you. So the conditions here include advanced COPD, heart failure, cirrhosis, kidney disease, or any stage 3 or 4 solid organ cancer. There's a team of analysts that will provide sort of a grouping of these are the people that are eligible, and then you're designed to sit down, go through the care plans with them, work on care planning, and then answer some surveys. There's 4 short surveys associated with it, and there is compensation for participation here. It's up to $5,500, and they are due approximately 13 months from now. So if you are interested in looking at this opportunity, there will be a link about this in the email that follows up on this session. Also, when people are trying to make sure that they're reaching their cycle goals for CME, a lot of the activities that are PPIP aligned will be able to give you credits on that. And with that, I will turn it over to Roland.
Thank you very much. Yeah, so I'll just quickly go through a few of the data sources that the HQCA can provide to physicians to help with some of these PPIP requirements. So if you're not clear on who the HQCA is exactly, we report directly to the Minister of Health, but we do operate independent from Alberta Health and Alberta Health Services and other healthcare organizations. And that allows us to provide an objective, a trusted, and evidence-based perspective. So I'm going to run through 3 tools the HQCA has to help provide data towards PPIP. Our panel reports, which have already been touched on, but I'll give a little bit more detail. One of our newest projects are our patient safety culture survey and our patient experience surveys, which are just in the process of being revamped. So the panel report, which is likely the one that most people here are at least somewhat familiar with, it is a confidential report to providers, about their patients, about their panel, including all sorts of panel characteristics, so things like size and burden of illness and deprivation indices, screening rates, continuity, patient utilization of services, inside and outside of the clinic walls. And those panel reports are confidential. They're not shared with anyone other than a physician unless it's requested to. And we do have a request system. And at that point, with permission, we can share them with PCNs, with clinic staff, anybody like that. What does it look like on this QI action plan template? Here's sort of an example of what it would look like for, say, a common one is cancer screening that people would use it for. So in this example, the physician would want to improve their colorectal screening rates by providing more fit test kits in the office. Ask the practice facilitator or nurse to use the panel report to identify patients due for screening. So it's pretty simple layout through the panel reports. For requesting your panel report, we do have a portal from the HQCA's website. You can go to request.hqca.ca or just go to our main landing page and follow some links towards improvement, tools for improvement, and you can request that panel report. As I mentioned, our newest project or product to help with this kind of work is our patient safety culture survey. So it's looking at the culture of safety within a clinic. And you can see some of the topics, communication related topics, standardization of processes within office, how well does the team work together to prevent errors, and a general perception of safety and quality within the clinic. So to participate in that one, you would reach out to my colleague, Jonas Schultz. You can do so through our main info at HQCA box. Takes about 10 to 15 minutes. We do recommend that all staff within a clinic complete the survey, or as many as possible, to have as robust a picture of what's happening in the clinic. Once those surveys are complete, we'll produce a data report and we'll help you identify some opportunities for improvement based on those results. Our patient experience survey, as I mentioned before, we are just in the final stages of some revamping after some of you may have been familiar with it over the years. We've run it for about 8 years. we found some places where we could streamline and improve some processes, as well as clean up some elements of the questionnaire. But you can see there's a few of the major topics that are covered through the survey. And those are things that are both very important from the clinician's perspective, but maybe more importantly, they're very important from the patient's perspective, especially around communication. If you want to participate in that patient experience survey, it'll take about 10 to 15 minutes for a patient to complete. All that's required of the clinic is we do need email addresses sent to the HQCA. Happy to discuss how that would work. But it is done at this point only over email, just because that's far and away the most efficient way for us to do that. And we will then provide a report. The only involvement of the clinic is in providing those email addresses. After that, they're done. And then we'll provide a report back to the clinic staff. And again, you can reach out to me for that particular one. You can go through the main email box or my name, roland.simon@hqca.ca. And with that, I will turn it over to someone else. I'm not sure who's next.
Thanks, Roland. That's me. So I'm going to be leading us, or starting off, just giving some examples of PPIP projects that have been done. Sometimes it just takes a bit of an idea to get people started. So we're going to go through a couple of examples of all the 3 different projects that you need to do. So the first one that I did was my practice-driven quality improvement project. Physician inbox management is one of the leading drivers for physician burnout. And we were trying to reduce the amount of physician workload by offloading culture results to be led by our nurses. So in my clinic, my nurses see most of my patients with strep throat and bladder infections, chlamydia and gonorrhea screening, that sort of thing. So the idea is that for those patients that my nurses have seen, for them to be following up with those patients. And so the way that I did that, on the next slide, I just collected some, this is just my action plan. I'll go over how I collected the data first. So the goal was essentially just to try to improve physician well-being, take a little bit off of our plates, spreading our work to our team. I work closely with our nursing group to help expand their scope and support them while they're doing that. So I worked with my team to do that. We had set a timeline to start by July of last year, knowing that it would take sort of multiple steps and small increments of change to spread it to the clinic. On the next slide, I think that you'll be able to see that I just created a tick sheet to collect my data. So despite all the vast amount of data that is out there for you to use, for this project, I felt that it was just helpful to collect a little bit of data for my EMR. So whenever I reviewed my lab test results, I got an idea of how many inbox items I had, what proportion of that was the culture results. I was covering a physician for one of the weeks that I collected data. So I did that data collection for 2 weeks. And then at the bottom of the screen, you can see how we kind of just did some reporting with our small tests of change. I developed some scripts to help with the nursing team. Turns out that they didn't find that overly useful, and they were already quite comfortable communicating these results with patients. We did our first cycle of change just with my patient panel. We started that in September of last year. We were a couple months behind. And then spread was to the rest of our clinic was delayed just because we had an EMR transition in this. One thing that sort of happened too is we concurrently implemented a change to try to just reduce overall urine culture testing based on the BC practice guidelines for UTI treatment. So while I haven't collected the follow-up data, I expect that my overall culture test results are probably going to be lower just simply because of that PDSA as well. And so by this year, we've managed to roll that out to all the different docs. And so I still have to follow up and make sure that there's no other kinks that we need to work through, but need to collect my last bit of data in order to kind of prove a difference with this. think on the next slide, we're going to hand it over to the team at Westview PCN to go over their examples from PPIP 2.
Good morning. My name is Amanda. I'm a practice facilitator with Westview PCN. And so for our PCN, we have developed a PPIP portion of our website for our physicians. And we're happy to share that link with you. It's just on the screen there. So the action plans we go over today are available for downloading and editing on our website. It cannot be found publicly, so you will need the link to find it if you would like to check it out. So the part that I'm focusing on today are the standards of practice. So these action plans have been created by myself with our PCN medical director, Dr. Laidlaw, who unfortunately is not able to join us today. All right, so the first step is to review one or two of the CPSA's standard of practices and identify areas of improvement and make an action plan. So we predict that the two sort of easiest and most common ones that our PCN might go for are virtual care as well as prescribing of opioids. And so those are the two that we'll go through today. So the opportunity is really like maybe not being reviewed. So not consistently documenting the confirmation of patient and physician in the chart notes of virtual visits. And so our SMART goal is just to reflect that and document it over the next 3 months. The physician and the practice facilitator would lead the change. The practice facilitator can help you create those macros and templates. And again, just reviewing that virtual care standard of practice and what what's required from that. The next slide, keep going. Perfect. The resources really are just the EMR and the time to make sure that it's being inserted. The barriers to compromise that success would just be like forgetfulness, not using that macro and template, and the time to do it and go through it. And then just using that template is like just the main thing, just to remember it's there and continue to use it. And then just going through and making sure that you are repeating that chart review to see that you are meeting all of those guidelines, and then just continue doing that quarterly to make sure that you're still on par with that. And then this is just the macro template that checks off all the requirements from that standard of practice. All right, so the next one is the opioid, prescribing of opioids. All right, next screen. Excellent. So the opportunity again is like you can, through the CPSA website, you can review the MD snapshot prescribing and generate a list of the patients who fall under that category. And then check that percentage of patients, and then have that reflect your SMART goal as well. So the opioid, I believe the opioid timeline is 6 months. And so just making sure that all of those patients have been checked within that 6-month period. The change, of course, would be the physician, but with the help of the pharmacist, nurse, receptions, and the PCN staff, like we can all help to implement that change. Again, using the template or a macro, knowing how to do that and to access Netcare. The barriers, of course, again, time and remembering to use it, but the strategies that you can use are logging into Netcare before each half day and making it quick and easy to use that and fill it out accordingly. The goal, of course, can be identified as meeting those requirements and checking through that those are being done, and continuing to check that MD snapshot of patients quarterly. Next. And then just like a quick how-to of how to access your higher risk patient list through the CPSA portal. Just going to the analytics and then view your MD snapshot prescribing. Click on the arrow for opioid patients all, and then at the top right to go to the list. For the opioid, so there's the two templates. There's one for the opioid start, and then so this goes through for all of the standard of practice for making sure that everything is, all the boxes are being checked for the opioid start. And then on the next slide we have for the opioid renewal. And that can just be used as to follow up with the patient and make sure, again, all the boxes are being ticked. All right, I will pass it over to Lindsay Naninga.
So for my PPIP 3 project, I had completed the insight profile when I onboarded with the AMA Act team. So for those unfamiliar with the insight profile, it's a type of, I guess, personality type test that gives you colors that help identify sort of how you interact with people around you. And I wanted to use that because it's quite a useful survey tool, and there's lots of discussion that can happen from that as well. And so I wanted to not just put that back on the shelf, but I wanted to be able to continue to review that so that I can increase my ability to work effectively with teams and new team members in my role as physician champion. And so the goal was for me to use that insight profile and then just make sure that I create yearly reminders and work with my team to review it. So in January of this past year, my colleague Krishna at AMA, him and I reviewed our insight profiles. We just gathered feedback and some thoughts about it, and he provided me some feedback with areas to work on in the future. And then the next step is just a reminder set for 2025 for me to do it again next year. So my action plan that I documented for this, really the goal was for me to increase awareness of my interpersonal function within the team. I work with a multitude of different team members, so it's important for me to be quite aware of that. My SMART goal was to complete that insight profile by the fall of 2022 and to have annual review of the assessment and how it contributes to team dynamics. I was essentially the one leading the change after that profile was completed. And obviously some of the challenges associated with that is my time and setting aside time for having a facilitated discussion. The barriers that I faced, some lack of feedback from the broader team members can be a problem. Also, time and actually following my calendar was challenging too. I was supposed to do it last fall, but it got delayed a little bit. And so I found it quite helpful with this project just to kind of rehash some of the things about my personality that are sort of strengths and weaknesses, and try to focus on working in a more, I guess, more functional manner with my teams. So that's my PPIP project. So I think we're going to hand it over to a question and answer with Dr. Michaels.
Yeah, so we're going to do some question and answer now. And so if participants, anybody in the group has questions for any of our speakers, so Danielle, of course, who's here from the CPSA, but also Lindsay, Amanda, or Roland, who've just spoken to us. You can feel free to come off mute and speak. If we start getting lots, you can also raise your hand, and then I'll kind of go in order as well. You can also type things in the chat, and I can read those out for you. We're also running a little ahead of schedule, which is great. We were all worried about time. So if you also have examples of things that you have done or you know of in your teams or community that you would like to share, also please share those with us so that we can all get some more ideas. So a couple questions that have come up in the chat already, I'm just going to start with while people gather their thoughts and think of some questions. So one question for Danielle is about the cycle. So the 5-year cycle, how does the timing of that work? Is it the same for everybody? Could you comment a bit about that?
Yeah, absolutely. So this is the $1 million question at the moment. So at the moment, anybody who is in practice, their cycle will have started on January 1st, 2021, which is when PIP was launched, and would finish at the end, December 31st of 2025 for that first 5-year cycle. However, we are hard at work aligning with the CPD cycles because every physician, in the province has their own CPD cycle, which will have a base of 5, but could be extended for various reasons, or they could be on a shorter cycle if they have not met the requirements. So anyway, stay tuned for April. You'll get a new PIP report. You may recall that you got a PIP report in your inbox last summer, and so hopefully this next PIP report will give you very clear information. But I will say it'll be fair. So basically in a 5-year cycle, you'd have 20 months to complete each PIP activity. In an alignment phase, if we extend your cycle, you'll have no less than 20 months to complete each PIP activity, even if the number of activities kind of extended for that initial inaugural cycle. So.
And I imagine, Danielle, you guys will give people gentle reminders if they haven't submitted anything. Will people get some kind of notification?
Yeah, absolutely. So Tanya's all on top of that. So you are asked on your RIF to say, what have you done so far? So certainly we'll be identifying in this learning phase people who perhaps haven't, talked about anything that they've done. It's very unlikely that you haven't done anything that could qualify as a PIP activity, because the aim for this is that it's approachable. So even small changes that you've made, noticing something that could qualify, will just get you to write down some stuff and help you out there. So yes, this is, we understand it's an educational phase as we're rolling this out.
Okay, thank you. So another related question is, if someone didn't put their PIP activity on their RIF for the previous year, is there any way to add that, or do they have to wait till the next year when they renew to input that?
I mean, in a limited way, like RIF is not, it's really right once. So if you do realize that you made a mistake, or if we audit you and it turns out you didn't do something that you thought you did, I mean, we certainly can on a limited basis edit those, but I wouldn't worry about it. Just make a note and put it on your next year's RIF. It will say, did you do it in the last 12 months? But if you realize you did something which qualifies and you didn't report it, just report it on your next RIF and don't worry too much about it. Yeah.
Okay, and then I think Dawn had a question, but I think it might have been answered. So I'm just going to read it out for everybody, that if you aren't sure if you put on your RIF that you have completed a PIP activity, and you want to look back and see if you have recorded that in a previous year, it looks like Tanya replied that they are available through the CPSA portal to see your previous ones. But only available to physicians to check their own.
So just to clarify, that'll be after we upload the PIP report. So when you fill out your RIF, you can ask for a PDF to be emailed of you of what you said. So if you did do that, you can certainly look back at that. Otherwise, I'm not aware of any way that you as an individual can see what you said on RIF last time. But what the PIP report will be is, in addition to containing that updated cycle information for you, just so you're really clear about what you need to do, it will also tell you what you reported on the previous year's RIF starting in 2021 or 2. There's a little bit of a change in the way the question was asked, but I think, yeah, just so you have a sense there. Yeah.
Great. So, and then Daryl's just commented that, yeah, there's lots of confusion just because it kind of rolled out during COVID. So I think I've noticed that too with chatting with docs, that a lot of people aren't aware of these new requirements. So it's really good that we're trying to get that information out there. So Teresa had a question about new grads who don't have a lot of data. Perhaps they don't have a lot of panel data yet. What are some ideas, and maybe anybody from our speaker group or anybody from the group in general could answer this question. What are some ideas for new grads that might not have a lot of data yet to work with?
Yeah, Andy, you might not have seen my comment in the chat, but one suggestion I would have is if they're taking on a panel of patients, they could look at what is their actual panel size versus ideal panel size. I sort of recommend every new physician does this so that they have an idea how many patients they can accept into their practice. So this is something that most PCN staff could help them with.
Just a new practice of amazing time to do experience surveys or any data work because it can provide a baseline. It gives you something to a marker to try to improve on for coming years.
Yeah, and I'll just add that you could look at any particular clinical presentation. I mean, I think somebody mentioned the BC UTI guidelines, and compare like what is your practice when you see people coming in for that. As a new grad, you're often seeing a bit more of that episodic care as you perhaps are filling up your panel. And so you could evaluate your approach to acute pharyngitis, to, you know, potential UTI, to STI screening. There's a whole bunch of things that you could do just looking at clinical practice guidelines for more episodic presentations. In terms of standard of practice, you could have a look at patient record content standard of practice. It's got information about what ought to be in the cumulative patient profile, you know, what should be in a history, and just, you know, do a chart review of 10 charts of patients you've seen and just see how well you're hitting those markers and pick an area for improvement. I did see a question in the chat about physicians who've joined, come to Alberta since 2021 or entered practice. Yes, of course, the cycles will be adjusted for that. So as I said, there'll be a fair process. I wish I could be a bit more specific, but we're, you know, stay tuned for big announcements. I promise I'm intimately involved and it will be fair, at least 20 months per PIP activity. Okay.
Great. So question from Jarrett. I'm just going to read it, Jarrett. For physicians looking to use the group practice review program as a way to meet their standards of practice QI activity, do you have any insight for what the turnaround time is for that request? Is there a minimum group size before that can be requested?
I will defer to Tanya, who runs our group practice review program, as well as PIP. So that's a great question.
Thank you. Yes, the group practice review, we define a group as more than 2 practicing physicians in a clinic. So any group with 2 or more. And the process can take 4 months, really, or a bit longer depending on schedules, because we do need to arrange to have a reviewer come in, and then it's followed by a virtual facilitation with all the physicians in the clinic. And I was going to mention that earlier, actually, with HQCA. That's something that the group practice review uses as well as the HQCA clinic reports, which are fantastic.
And we have a question about shared action plans. So what's important to keep in mind? I mean, CPSA regulates individual physicians. It's important that each individual physician has some work to do or some reflection, some change in practice. But yes, absolutely. You know, I worked with a clinic, that wanted to look at pulmonary function testing for their patients with asthma and COPD, which is something which is reported on HQCA's clinic report. So it really, the action was more at the level of the clinic, but at the same time, each physician was kind of aware, oh, that's a gap. If I'm seeing a patient in front of me who's on inhalers, I'm reminded to think, oh, gee, this patient may need pulmonary function testing. Let me look. So although it's perfectly fine to share an action plan, but just to keep in mind that we're hoping for individual reflection and QI.
Great. Thanks, everyone, so far. So Amanda had a follow-up question to the question about new grads and projects for them. So she was wondering about projects specifically for physicians without panels. So maybe those that do walk-in, work in hospital, do ER, those kinds of things. Does anybody in the group have ideas for projects that they could do?
So I'll just leap in. Absolutely, using the MD snapshot. Antibiotics may be even more fruitful for people doing more episodic care. Adherence to episodic presentation clinical guidelines. I did some templates. I'm presenting to a group of emerge physicians, I think, in the next couple of weeks. So I did do some stuff. So continuity of care in an episodic way. How are they ensuring that they're in adherence to the continuity of care standard of practice? In terms of, do they know if the clinic that they're locuming at has an after hours, way to be reached for, investigations that they ordered? If they do order a high risk investigation, are they making sure to have that communication piece with whoever's on call for the group, so that if there's a reasonable likelihood that something could come back after hours? So I think there's lots of things. So both, clinically with acute presentations, which aren't going to require, and then making sure that they're in compliance with that continuity of care standard of practice for episodic care physicians. It applies to anybody who has a patient interaction.
I have a slightly related question. It's not really about PPIP, but it's about continuity of care and documentation. I've received this question from a lot of physicians who are doing their continuity of care standards of practice review, and they're wondering if they need to have some kind of document from their PCN, for example, that states that they have this fixed formal relationship with an after hours clinic. And so they've been requesting that of their PCN, that they would like some kind of document stating that they have an after hours clinic. Would the CPSA ever audit and want a document like that? Or if a physician self-reports that they have a relationship with their PCN for after hours care, is that sufficient?
So what I think the SOP says is evidence of an agreement. So an email would be sufficient. Clearly, the more formally it's documented, the more safe harbor you have. I always, when I'm chatting with physicians about this, I think, just like what happens if you have a patient who seeks after hours care, but something goes wrong, or they don't know about it, or there is perhaps a misunderstanding with who's providing the after hours care. I mean, that's a vulnerability for the patient's safety. So it doesn't have to be a contract drawn up in triplicate with, whatever, but we say evidence of an agreement, and we say, it's not sufficient to just say on your answering machine, go to this emergency department, unless there's an agreement there. But obviously in smaller centers, it's the same physicians in the emerge and in the clinic. And obviously if there's a long-standing agreement that the emerge is providing the after hours care, there's going to vary. It's not going to be one size fits all. Yeah.
Great, thanks so much. And then
we do ask that, sorry, in the group practice review, we ask about who do you have and is there evidence of the agreement. It's a quality, it's a standard of practice to have that, which is what physicians are held accountable to in case there should be a complaint. Yeah.
Great, that's very helpful. So there was a couple of other comments in the chat too about ideas for kind of new physicians without panels, about MD snapshot and CVD risk screening as well. Yes, if there's other examples that people want to run by our team while they're here and while we have their ear, feel free to come off mute and kind of share ideas. Ernst, you have a question?
Thanks, Annie. Thank you for this wonderful collaboration between different partners regarding PPIP. One of my examples that I just want to share is, and perhaps just for those of you who want to go through this as well, we go through every 4 years, we go through a medical device reprocessing and an IPAC review as well as, and so what we did in our clinic is we actually used that as a standard of practice review for our clinic, the year that we actually had to go through the audit. So that made it much easier for us. We didn't have to duplicate the work. So I think if you can align some of the standards of practice reviews that you want to do with other things that has to happen automatically, that just helps without having to duplicate it. And it actually got the whole team on board with our process.
That's great. Yeah. So kind of looking for opportunities when you have to do something else anyways to reduce work. That's a great idea. A lot of physicians are kind of concerned about the work that these involve. So it's nice to learn some easy ways to do this. I guess on that topic, I get some questions sometimes from physicians of kind of why did this change happen? Why am I being asked to do a bit more? Is there anything that I guess our two people from the CPSA can comment on as to what brought about this change and if it's aligned with other provinces?
Yeah, that's a great question. And when we do the presentation, it's one of the questions we say. So, PIP is not, so we have a legislative requirement as the medical regulator to ensure competence in the profession, and that includes a whole area about general assessment, so both quality assurance and quality improvement. So as Ernst mentioned, IPAC is about medical device reprocessing. We have our physician assessment and feedback program, which is a screening practice visit program, aimed at assessing higher risk practices to see whether we can intervene and help avoid harm to patients. And we used to have a thing called PAR, which many people may remember, which was our way of fulfilling our assessment of all members of the profession, because we actually we're responsible for assessing everybody, not just the higher risk. But PAR really, in the way that it was put together, only about half of all physicians were actually eligible because you had to be clinical. So about half of physicians were always exempted from it. And we actually have a research department at CPSA to see whether what we're doing is helpful. And so when we reviewed the data from PAR, although the studies had been very promising, the people who were involved in the trials found it very helpful. As a whole, physicians did not find it helpful. That was about 2016 or so. And about that time was the move nationally to the QI. Many of them are published in peer-reviewed journals. Trevor, that's a great question. If you reach out to Tanya, she may be able to hook you up with a list of publications. Lots of really interesting stuff going on, trying to do evidence-based regulation. In 2016, I think FEMRAC, which is the Federation of Medical Regulatory Authorities of Canada, published it's like a white paper or something. So it's on their site, it's publicly available, talking about quality improvement as the future for general assessment, really aiming to foster a quality improvement lens in the profession to move from good practice to better practice rather than, going with the old, like, is this adequate? If it's adequate, you don't have to do anything to improve, recognizing that there's opportunities for improvement no matter how awesome you are. And I think physicians in Alberta are pretty awesome. So Ontario has a huge QI thing. They have QI facilitators. You have to do a really big QI project. I don't know exactly what the timeline is. So many other, BC has a very similar program. So yes, across the nation, this is becoming more common, and potentially, eventually, these may be folded into the CPD organizations, MOC and MainPro, but at least at the moment, these are being rolled out on a provincial level. So our aim with PIP was to create something that's applicable to you, no matter if you're a pathologist or a radiologist, or you only do teaching, or you're a family physician in a tiny town with your team is your one MOA and you don't even belong to a PCN, or a really large urban practice of academic specialists that's has access to all of the might of the educational institutions. So it doesn't have to be big to qualify as PIP, and that's deliberate. That sort of high level is deliberate as well, which leads to a little bit of vagueness. And people are like, well, what do I actually have to do? This is not a tick box. This is like, reflect on your own practice, identify the opportunities for you or for your group, and then act on them, and then modify what you're doing based on that data that you're getting back, a true QI type of approach. So that was a long answer, but I hope it's been helpful.
Definitely, that's helpful. Thank you. Any more examples from the group or questions for our crew here today? Got a comment about choosing wisely for some project ideas as well. That's a great idea.
Yeah, there's fluoroquinolones that are called out in your MD snapshot for antibiotics. So, there's some good information on deprescribing or rarely prescribing fluoroquinolones. That would be a little standalone project you could do.
So Danielle, I just want to make the comment that a lot of the family physicians have stated that they're overwhelmed. They've got administrative overload, and they feel that this is just one more thing to put on them that's going to take time. And what we're finding is some of the family physicians with the least resources, meaning they're maybe not part of a PCN or a smaller PCN or not at all, are having to do this work on their own, and it is time consuming. I mean, I did a QI project on my own with no help, and it was 4 to 5 hours of work, and I know how to do QI. I'm trained in it. So what is your answer to that?
I guess I just really, remind people that they're often doing this work already. So recognizing it, for example, the guidelines changed for routine urine dips in prenatal visits a little while ago, and many clinics immediately moved to change that practice. That's a QI improvement that they did. Many clinics, do reach out for screening initiatives, and even small ones, like opportunistic type of screening improvement. So we're really hoping that physicians are recognizing all of the ways in their ordinary life, in their ordinary practice, that they're already trying to improve their quality. Both. So I just really feel like or look at the example about having the nurse manage the culture results. Maybe it's not maybe they don't have access to it, but maybe they do. That's a way to offload the physician and use the team better. Is there something in the inbox that could be handled or appropriately delegated? So we totally appreciate that this is, I'm, by the way, until quite recently, I was a full-time practicing family physician all through COVID. I still do a half day of clinic a week to keep myself honest, because in the work that I do, I am assessing practices and so on. So, I really deeply resonate with that. I wasn't with a big team. There was 4 of us. It was busy, community practice, did not have access to QI machinery. I'd say just look for the little opportunities. What about weights on your patients or blood pressures? We assess practices where the last time someone took a blood pressure on a patient was 3 years ago, and they're on antihypertensives. Even just making sure that you make a point of taking the blood pressure on your patients on antihypertensives on a Q6 months or annual basis, which you should be doing anyway. That's not a whole lot of change in the amount of time. So I think it's a frame shift more than a glib answer. And I appreciate that it's hard for people to be perceiving this as being asked to do a lot more.
For sure. I like that answer, Danielle, because it's like, look for opportunities that are going to actually improve your workload and make it a useful project rather than a make work project. So I think there's always lots of opportunities for that in family practice. And sometimes they're bigger projects than the easy ones that are just a tick box, but they're the ones that make the biggest difference for sure. There was a few more questions that came up in the chat. So one was just about some more ideas for personal development projects. And I think some people shared a few things already. Trevor shared a journal that he is using. That's really neat. So we're going to check that out. And then someone else commented on some ideas here using the burnout index. So that is something that is rolling out to a lot of the PCNs in Alberta as well. Like ACT is helping put together a burnout webinar, and that satisfies the personal development project for people. So there's that, but you can also do it on your own. So if you're kind of looking to get this done and you're not sure if and when it's going to come to your PCN, you could do a burnout questionnaire as your objective data on your own, just kind of get a sense of where you're at already, and then have a discussion with maybe a colleague about kind of what your results were like, and then make an action plan based on that of how am I going to improve this a little bit for myself? Am I going to set a bit more limits in my day? Am I going to take up a hobby that helps relax me? Am I going to spend more time doing the type of work I want to do, a bit more teaching and a bit less clinic, something like that? That would be a personal development project someone could do on their own, and we facilitate that discussion. But if you, yeah, you could kind of do that with a colleague as well.
I just wanted to say, sorry, I just want to say a couple things about the personal development. I think it's really important to note that we would never ask for your action plans. So you really can work on fairly personal things. Like we might, you don't have to be specific in the action plan. Or if you worked, say, with a counselor or a coach as a facilitator, and you talked about quite personal things, in the rare case that we would ask for an attestation, it would be perfectly fine to say, I worked with this person on a personal development project. They don't have to give details. So I want to be really clear, you're not turning in anything of a personal nature. So the idea here with the personal development is to try to enable something to count on your personal wellness for something like this, because we know that physician wellness is an important pillar of healthcare quality. And then I also wanted to just let people know that they can reach out to Tanya or PPIP at cpsa.ab.ca to volunteer to be an MCC 360 participant. And CPSA covers the costs of that and the cost of the facilitation as well. Don't sign up through the MCC directly. You'll be charged quite a bit of money. But if you sign up through us, there are limited spots, but we still got room, I'm sure, this year. You can, that's another way to fulfill your personal development.
Andy, there was a question that maybe got lost in there about are there requirements the same for doctors only doing locums? And Danielle can nod her head, but I believe the answer is yes. Yeah.
Yeah.
Great. And then the next question I see here is if anybody has experience with my PI. I don't. Does anybody have any comments about that?
MyPie, I haven't used it specifically, but it is a program available through the University of Calgary, and it helps you sort of document and gives you tips about doing QI projects. There is a fee associated with it.
They did write a Messenger article quite recently, I believe. Maybe Tanya can nod if I'm correct. Yeah. Actually, if you look on our website too, I mean, we've done more than 100, well over 100 presentations about PIP, and there's about 20 Messenger articles about PIP. So there's a lot of information, maybe just worth just searching on our website for PIP related Messenger articles, and MyPie and whatever the U of A one is, both did articles recently.
Great. And then there was a question here, a comment and a question where someone has written that they worked on a ALCS program, and during, I actually don't know that acronym, so maybe the person could come off mute and describe a bit more, and found out there's not much documentation about smoking status. So they adopted this process in their clinic. Would tobacco documentation be considered a standard of practice requirement? So I know that there's about 50 plus standards of practice on the CPSA website. Danielle, have you memorized them all? And is that one of them?
Well, one of the hazards of taking this job on, I'm certainly much more familiar with the standards of practice than I was as a practicing physician and even a practice visitor. But I would say that actually could fit into either a practice-driven or a standard of practice. So the patient record content one has a section on what should be in a cumulative patient profile. So obviously smoking status would be one of those. So you could certainly do a standard of practice-based one where you just did a push for documenting everybody's, smoking status. On the other hand, obviously it's a clinically relevant piece of information for screening for bladder cancer, lung cancer, et cetera, COPD. So that would also fit onto the clinical side. So you could use that information in either kind of a project.
Great, good to know. And yeah, so all of those are listed on their website if you have to kind of check to see if your project qualifies as a standards of practice. can kind of check out the CPSA website. And okay, so ALCS is Alberta Lung Cancer Screening. Great. Thanks for clarifying that. So I think we're kind of running out of time here. So are there any last burning questions? If not, I think I'm going to hand it back over here to Janet, who's going to wrap up for us. Thanks for all of your great questions, everyone, and thanks for our panel for your answers.
Yeah, what a great session and so much information, so much sharing. Great. Just a reminder to the physicians that these sessions, if you attend them live, they are certified, and you can get your certifications if you go to your member dashboard on AMA and go to the CME webinar certificates. They do take a few days to show up, a few weeks to show up. So some people just go every 6 months and print off the ones that they've attended. If you can tell people if they look at them on the YouTube channel, they could claim non-certified credits for that if they wanted. So our next sessions are April 9th in the evening and April 10th in the morning. And charting tips, we were talking a bit about that. So working smarter, not harder. A reminder that a summary email with the evaluation link will be sent out, and want to thank everyone. I just saw in the chat someone said, can we get a copy of this? And yes, it will be up on the ACTT YouTube channel, and it will also in the summary email, there'll be a link to it as well. Correct, Michelle? Yeah, she's nodding her head. Great. And thanks again to Dr. Danielle Michaels and to all the other physicians for their examples and participation. It's been a great session. And if you have other ideas or feedback, please don't hesitate to send us a message. So thank you very much, everyone, and have a wonderful day. And we'll go from there.